Okay, good morning everybody. I'm happy to be the first speaker of this course. So I will be speaking shortly about congenital short femur classification. And before we start, we need to talk a little bit about terminology. So when we talk about CFD, there are a lot of variations in terminology regarding any kind of deformities involving the femur. It's a very wide spectrum of disorders, CFD. It can range from very simple shortening of a normal appearing femur to a complete absence of the proximal two-thirds of the femur through P50, as you can see on the right side. Some key points regarding the pathology. The overall incidence is CFD is 1 to 50,000 or even more. Many times there are deficiencies of the hip joint and the knee joint that are a major component of pathology and of treatment. There are some reported abnormalities associated with CFD, fibrillar hemimelia, patellar aplasia or hypoplasia, absence of foot raise, and syndactyly of toes. Regarding the femur deformity, I will not elaborate on too much. I think Christoph and Scott will do that in later talks. But it varies from normal hip anatomy in very mild cases to severe coxavara in more severe cases. The proximal femur presents flexion and retroversion usually of the upper femur. And distal femur demonstrates a valgus deformity, often referred to as hypoplastic lateral femoral condyle. Regarding length discrepancy, the growth ratio of the short limb compared to the long limb remains relatively unchanged throughout growth. And this is a very important component, a principle, because final LLD, as skeletal maturity, can be predicted from the initial radiograph using the multiplier method that we will elaborate on later as well. About the clinical presentations, so usually, of course, we have apparent LLD. The hip usually presents with external rotation deformity, FFD, fixed flexion deformity, limitation of abduction because of the coxavara. The knee sometimes presents fixed flexion deformity, hypoplastic patella, subluxated or dislocated patella, instability of the knee, and sometimes we have ACL deficiency and anterior dislocation of tibia on femur with extension. Ankle is very diverse, a lot of clinical presentations, but we many times see limited dorsiflexion and hypermobility of the ankle with increased eversion. So regarding the classification, so all the classifications are based on plain radiographs, but as you can see here, sometimes it's really hard to understand the true anatomy and mechanism of the proximal femur, and that's why neuroclassification system use MRI, and with the MRIs we can see and understand the non-ossified femoral head, the non-ossified acetabulum, the labrum, pseudoarthrosis, and the condition of the muscles. And on the bottom right, you can see like the huge difference in the muscle condition between the right side and the left side. So there are many classifications systems that have been described over the years in an attempt to categorize and the pathology and to direct the surgical intervention that we want to do. The most famous one is, the oldest one is Aitken from 1959, and it was used worldwide. But we will mostly elaborate on the palette classification, which is the common language and the classification we are used to talk about when we talk about the pathology. So the palette classification is based on the degree of development and integrity of the femur. It's not edge dependent, and that's what's special about it. Type would not change with the degree of ossification of the femur during the age. And the classification types and subtypes each have a separate surgical reconstructive plan. So in general, we'll go through it slowly and elaborate on the things that are most important. So Peli type A is intact femur with mobile hip and knee. That means the hip, the femoral head, and the femur move together as one joint. Type 1A is normal ossification, and type 1B is delayed ossification. Type 2 is mobile pseudoarthrosis, so there's true disconnect between the femoral head and the femoral shaft. Type 3 is diaphyseal deficiency of the femur, so the greater trochanteric apophysis is not existent, it's absent. And type 4, which is not really P50, is more distal deficiency of the femur, and proximal end is normal, and that's a rare pathology. So to make things a bit more complicated, we have some sub-classifications. We will not go through all of them, only on the important stuff. So we'll dive a little bit into 1A. So we said it's intact femur with mobile hip and knee, with normal ossification. And the subtypes, 1A1 is just hypoplastic femur. That means we have a short femur. Type 1A2, we have some dysplasia and some retroversion. And type 1A3, we already have some coxavara in addition. When we dive into 1B, so 1B, as we said, it's delayed ossification. So the delayed ossification can be in two main anatomic areas. So it can be the subchondritic type. Here in the picture, you see the white stuff is where the delayed ossification is. That's subchondritic. This is femoral neck type, and 1B3 is combined. So we have delayed ossification at the femoral neck, but also in the subchondritic area. So, type 2, we said it's true disconnection between the femoral head and femoral shaft. The graded trochanteric apophysis is not existent, and knee is usually mobile. We will not go through the subtypes. Type 3 is diaphyseal deficiency of the femur, so no graded trochanteric apophysis. We will not go through that. And we said type 4 is distal deficiency of the femur, and Pelly said he just put it in because he didn't want to leave it out. But it's not a true PFFD. So we'll go through some clinical cases just to try to make it more clear. So this is a 3-month-old patient, and this is him after 4 years. You see a normal anatomy of the hip joint, and the only thing that is apparent here is the LLD, and this was treated with first lengthening, and we plan to do more lengthening. That's at the age of 10. And as we said, this is normal ossification and no dysplasia, so this makes it 1A1. Next case is a 7-month-old patient. As you can see here, there's the valgus of the left lower limb. And here you can see that we have performed a Dega osteotomy in preparation for lengthening. And as you understand, this is a 1A2 because we have already dysplasia that was needed to treat prior to lengthening. Two more difficult cases. This is a 2-year-old patient. I just zoomed in to see the left femoral hip joint. As you can see, it's not totally understandable in the X-ray what's the condition. And in the MRI, you can see delayed ossification at the femoral neck where the arrows are pointing. And that makes him delayed ossification type 3, 1B3, because we had delayed ossification at the femoral neck and at the greater trochanter. And this is him at 4 years old. Again, Dega osteotomy in order for lengthening. Notice the fibular hemimelia, and please note also the anterior dislocation of the tibia with extension, and I magnified it so it's more clear. Last example, this will be the hero of our day. This is the case that we're going to operate in the live surgery. This is him at 7 months of age, and as you can see in the movie, you can see the delayed ossification. I will let it run. This is him at age of 2 years. This is his MRI at the age of very recent MRI. You can see the delayed ossification. And this makes him 1B3 as having delayed ossification at the neck and at the greater trochanter. And this is the last slide. This is 3D construction of him, very recent for his CT. Thank you.